So my name's Andrea Gropman. I'm a child neurologist and a clinical and biochemical geneticist at Children's National. And so, like I said, my task is to, in about 25 minutes or so, talk about how the brain works or how it doesn't work. Okay, so I see the next slide, but you guys don't. Okay, so basically, as neurologists, we like to think about the brain and the rest of the nervous system as two separate groups. So we talk about the central nervous system, which is the brain and the spinal cord, and we talk about the peripheral nervous system, which are your nerves and muscles and the connection between them, or the neuromuscular space. But basically, the function of the nervous system overall is to control all your motor, sensory, autonomic, and cognitive functions in the body. And so, like I said, we break it down into systems. So the central nervous system comprises the brain and the spinal cord. So problems with your brain or your spinal cord are referred to as having a central process. And then if you have a problem with your nerves in your body, your muscle, the neuromuscular space, that's a peripheral disorder. And then the autonomic nervous system is kind of your fight or flight. So those are the parts of our body that we don't think about. The functions we don't think about are heart rate or respirations, peristalsis, or the movement of food throughout our GI tract, things like that. And so what makes up a functional brain unit? So we have a neuron or a nerve. They're called different things. I'm just going to use the arrows here because I think I screwed up everything else. So we have the central neuron. It has a center. The nucleus has some important functions there, the body. And then there are these connections here where it can interact with other neurons. And then there's this long, long fiber called an axon, right? And then at the end of the axon, it kind of branches off. It looks like maybe a tree branch. And so you'll see that also on the axon are these little kind of bubbles or packets. So the axon is the major extension of your neuron that carries information, in this case in the form of electricity, down to the end of the neuron. And then this will lead to a chemical process that then communicates with either another neuron or in the peripheral nervous system with a muscle. And so why do we have these packets? And what is this stuff? So this is called myelin. It's a fatty substance, and it basically achieves the same function as your wires here, right? So if I were to strip this off, there would be copper wires inside, and the computer, whatever this is hooked up to, I'm not sure, I guess it is the computer, would not work as quickly because charge would be lost. So the same function for the myelin in your brain and also in your peripheral nervous system, as it serves to isolate the electrical current so that charges can go quickly and signals can go quickly. Because when I move my hand, a lot of different neurons and muscles are firing, and it's very fast, right? So I'm not doing it in slow motion. I'm able to pick this up really quickly. So that's what we want to happen. Now, of course, there can be conditions where there's damage to the myelin, and the signals can be very slow or may not even effectively work at all. And we'll kind of talk about some of that later. Now let's switch to the muscles, right? So we still have the same type of basic concept where we have a neuron and we have an axon that passes signals through that long, and axons can be very, very long. And then instead of at the end where it's branching off, we don't have another neuron, but we have a muscle fiber. And so I think this picture shows a little bit better that at the end of this branching network, which are called dendrites, we see these little bulbs or boutons, and these contain chemicals known as neurotransmitters. And they're different chemicals depending on what neuron it is and whether you're in the brain or you're in the muscle space. And so although it looks like they're exactly touching, there's actually a little bit of space where the chemicals have to travel. So when the electrical signal comes down the axon, it signals the release of these little chemicals that are called neurotransmitters from those boutons, and they travel through a space and they have to find where they need to go. So there are receptors on the muscle or on another nerve if we're in the brain that take them up. And then in this case, it would cause a muscle contraction, or it could cause an inhibition of movement, depending on what the neurotransmitter is. Okay. So what symptoms come from brain and spinal cord? So if you look at the first picture, the little baby is just draped over someone's arm. So this is a baby who's very floppy. It could be a brain issue, right? So we get our tone from our brain down, or it could be weakness. I can't necessarily tell from the picture without examining the child. It's just a floppy child. So it could be a muscle weakness. So having low tone, it doesn't necessarily mean that you're weak. You can actually, still have muscle strength, but your ability to kind of move your muscles against gravity is impeded. And then in the second picture with the fist, so that would be increased. So as opposed to being a child having hypo or low tone, here we have someone who's got too much tone and they're fisted, right? So they're not able to move across that joint and they get a contracture if we don't do therapy or we don't do bracing. And then also we have to remember that our brains are important for higher cognitive functioning. So reasoning, problem solving, evaluating, critical thinking, math skills, everything we need to be successful in school and later in life. And so there are several things that can affect that. And one of those that I'm going to talk about is seizures. And I'll be talking about that after subsequent slides. So what problems come from the muscle unit? So muscle weakness is the most common, right? And it may be so severe that someone can't walk and they have to be in a wheelchair. Other manifestations of muscle weakness can be limited to certain muscles. So you can have diffuse muscle weakness all over, or you could have more of a focal weakness. So some of the things that we see that might be more focal are in the face. So you may have droopy lids from something called ptosis. So the eyelids are not able to stay open because there's muscle weakness, or there can be weakness of one of your cranial nerves. And one way to test that is to try to fatigue the muscle. So in general, muscle weakness can be present all the time, or it can be manifest after periods of fatigability. So in the clinic, we try to do maneuvers or procedures to bring that out, right? Because as someone mentioned yesterday, their child who has Kern Sear did well on the 6-minute walk test in the morning, but if they had tested him in the afternoon, may not have done so well. So that implies that there's some fatigability. So if we don't know that in the clinic, we can't really understand the breadth of the neurologic symptoms. So some things we may do is have someone repeatedly look up for a while and then look at their lids and see if they start coming down. Other things we can look at are the face, a smile. Does the person use their full face to smile, or is it more like a snarl because they have some muscle weakness in the face, or do they have no expression at all in the face? And then the same with muscles. We can try to fatigue a muscle. We can have somebody repetitively sit in a chair and try to get up, and sit in a chair for a while and get up, or sit on the floor and try to get up. And that would test the more proximal muscles. So like your butt muscle, your hip flexors would tell us if you're weak there, if you have increasing difficulty performing that task over, a short trial of repetition. Okay, so one thing that can go wrong in the brains is stroke. So it's also called a cerebral vascular accident. And so when people think of stroke, they think of, grandma stopped talking and was weak or had some numbness in her face and her hand or arm. And it's a medical emergency. And so the most classic type of stroke is due to a blockage. So you have a clot and blood's not getting to a part of the brain that needs to perform an important function. But in metabolic disorders and in mitochondrial disorders, we talk about metabolic strokes. And these are also emergencies. They're also rapid onset, and they can have lasting central nervous system neurologic function and associated typically with some sort of metabolic decompensation in the patient who has the metabolic disorder. So time is of the essence, right? So a metabolic stroke may occur if someone has a decompensation. They may have a viral infection, they may be dehydrated, they may have had surgery. There are a number of precipitants for that. And then the patient really needs to be managed by a center that has capacity to understand the implications of metabolic stroke and has treatment protocols. Now, metabolic strokes are not unique to mitochondrial disorders. In fact, there are a number of other metabolic disorders in which stroke is unfortunately not that uncommon. And so I've listed them here. And even within mitochondrial diseases, there can be several different genes for that condition that are implicated with stroke. And so here I've listed MELAS and Leigh syndrome, but also other metabolic disorders such as Fabry's disease, propionic acidemia, glutaric aciduria, some of the glycosylation disorders, homocystinuria present with strokes, but the mechanisms may be entirely different, but they're still medical emergencies. Stroke in MELAS is particularly important to recognize. Some of the patients may present with a seizure, right? And you think that you're just treating their epilepsy, and then lo and behold, there's a functional deficit. And so, you know, there's a difference between a stroke and MELAS and a stroke from a cardiovascular blockage, right? So we have to recognize that the treatments are going to be completely different. And a lot of the patients who have a stroke due to a metabolic disorder need to be managed in a facility that really can understand what they need and essentially need to be put on protocols to prevent the next stroke. And in general, stroke, whether it's due to metabolic disorders or a cardiac issue, are typically hard to predict, right? So if you've had one stroke, we can't necessarily say when or if the next one may occur. So adhering to your protocols is going to be very important. With regard to muscle, so muscle weakness in general is referred to myopathy. And basically abnormalities of the muscle cell can lead to weakness that can be fixed or it can be fluctuating, as I've discussed. And as neurologists, basically the time course and the distribution help us distinguish, you know, what muscles are involved or what the underlying etiology may be. In mitochondrial myopathy, there are a couple of additional factors that we need to take into account. One is that some mitochondrial disorders that have strokes are not immune from having muscle weakness as well. So we can see a mixed picture of both central nervous system and peripheral nervous system disorders in the same patient. So one example would be some patients with MELAS syndrome who have strokes also may have more of a myopathic feature as well. Meningi, which involves smooth muscle. So we have to remember that muscle is not limited to our skeletal muscles, but we also have a big, large muscle in the middle of our chest, which is our heart, and that can be affected as well. And our smooth muscle that line our organs, particularly our GI tract. And the muscle disorders can be very limited. So for example, in progressive external ophthalmoplegia, we may only see weakness related to eye movements. So patients are not able to achieve the full range of eye movements laterally or horizontally. And then there may be certain clues on muscle biopsy. So patients who have a particular type of mitochondrial disorder known as MRF have epilepsy, but have this very distinct, what we've been calling ragged red fibers. And that's based on a histopathologic evaluation of this clumping of a stain that indicates the damaged mitochondria in that individual. Now, in distinction to that, we also, we're back. We have it's in and out. We have a group of disorders that result from problems with nerves. Can you hear me without it? All right. Sort of. Okay. It's like in and out, so we'll just deal with it. So a group of disorders that result from damaged or malfunctioning nerves can also cause weakness. So we can have weakness because the muscle itself is damaged, or because the nerve which provides information to the muscle on firing is itself damaged as well. There are a number of non-metabolic causes of neuropathy, and particularly in adults who tend to have some of these comorbid conditions. It's really important to make sure that we don't have something treatable, because we always want to look for treatable disease and treat it when it exists. So other things like diabetes or vitamin deficiencies, autoimmune disorders, infections can cause nerve problems as well, neuropathies. Neuropathy and mitochondrial diseases can be associated with certain of the mitochondrial disorders, and in particular, those that are involved in complex 5, like NARP, as well as mutations in proteins that are involved in fission fusion of the mitochondria. And people have described the neuropathy in 2 ways. You can either have a negative symptom, so numbness, or positive symptoms like burning or pain. And so painful neuropathies are sometimes difficult to treat. Numbness is also a problem because patients may not be aware of their sensation, in particular their lower extremities, so they're prone to injury. They may step on something, like Lego that's all over the room in the playroom and get an injury, and then later see a big ulcer and not realize how they got it because they did not feel it. Seizures. So seizures can also occur in Leigh syndrome and other mitochondrial disorders. So what is a seizure? It's a sudden, uncontrolled electrical discharge in the brain. And these are also emergencies too. A seizure is not just shaking all over like you see in the movies. In fact, there are many different types of seizures. And depending on the age of the patient, the seizures may be different. So a seizure in a neonate, for example, would look very different from a seizure in like a 60-year-old. So it can cause changes in behavior. There may be a momentary lapse of behavior where the patient is staring and they're not paying attention to you. Patients can also have focal seizures where only one side of the body is involved. It can start as focal and generalized. It can start at generalized at onset. There are some seizures where you just completely lose tone and you fall down. So there are many, many different types of seizures. And if you have more than one seizure, at least 24 hours apart, and it's unprovoked, then you're considered to have epilepsy. So people are confused about the difference between having a seizure disorder versus having epilepsy. And so it's more in the semantics. So 2 or more seizures, you have epilepsy if they're unprovoked. If you have fever seizures or febrile seizures, we tend not to call that epilepsy. And so again, there are many different types. They can vary by where they begin, how far they spread. Most seizures are going to be short and self-limited. A seizure that lasts longer than 5 minutes is generally a medical emergency because there's the potential that it could lead to what we call status epilepticus, which is either a seizure that does not stop after 20 minutes or more, or seizures that kind of start and stop within a 20 to 30 minute period. After a seizure, a patient may have temporary confusion and they may not recall any of the events during that period of time of the seizure. Although some people may have what we call an aura, where they feel doom or gloom or something's going to happen, or a headache or something in the pit of their stomach, and then they may go on to have a seizure, but not everybody has an aura. So basically, how does a seizure occur? So as I've shown, the neurons create, send, and receive electrical impulses, which allow them to basically communicate with one another. So if there's a disruption in that communication pathway, it can lead to misfiring. And sometimes seizures can be triggered by factors that can be controlled. So such as fever, so treating a fever, lack of sleep can also trigger seizures. Some people are very sensitive to flashing lights or moving patterns or other visual stimulants. So some of the same triggers for migraine, for example. And then medical conditions. So certain medications, as well as decreased salt in their body or decreased glucose, may also trigger a seizure. Certainly anything that is structural in the brain, such as bleeding, a stroke, a tumor, use of illicit drugs, alcohol, and COVID-19. Patients can present with seizures as the first manifestation of COVID. So these are some of the signs and symptoms of seizures that we see in Leigh syndrome and mitochondrial disorders. And then as well, patients can have speech and language deficits. So in addition to having seizures and strokes and muscle and nerve problems, there can be disturbances of higher cognitive function. So what's the difference between speech and language? So speech is basically how we say words. So it's the output. And people with speech problems may not say their sounds clearly. They may have a hoarse or raspy voice, or they may have a pause or repeat sounds. So they may have stuttering or stammering. Whereas language, if we talk about verbal language, are the words we use to share ideas and to get our needs and our communication across. And so people who have language deficits may also have problems understanding what other people say to them. They may have problems reading and writing and just being fluent in their conversation. So the brain kind of works like a big computer. It processes information that it receives from the senses in the body and then sends messages back. But the brain can do more than that. And it's more than just a simple machine, because humans can think and experience emotions. And it's the root of human intelligence. And so in the last couple minutes, I'm just going to talk about some of the parts of the brain that might be relevant to mitochondrial disorders, especially when there's dysfunction. So the cerebrum is our thinking brain. That's the brain that integrates all of our impulses, all of our motor activity, and controls our higher cognitive function. And it gives us insight and judgment. It's broken down into certain lobes. So the frontal lobe is mainly our executive function or our judgment and insight. The temporal lobes on the side are for memory, and parietal processes sensory information and orientation, and the occipital in the back is our center for vision. The cerebrum also has deeper sections that are often injured in patients with Leigh syndrome. So people may talk about the basal ganglia, for example, the brainstem. Again, these are relay systems that relate information back to the brain. And there's a right and a left half known as hemispheres. They're connected by a large band of fibers called the corpus callosum. And so the cerebrum also controls our movement, as well as processing sensory information, conscious and unconscious actions, and is responsible for our higher intelligence. Okay. The two hemispheres have to act together, but they do separate things. So the left hemisphere is more for speech and abstract thinking, particularly in right-handed individuals, whereas the right side is more our spatial orientation. Okay. So many of our functions come from the frontal lobe, including coordinating voluntary movements, assessing future consequences of current actions, being able to distinguish things that are similar and different, and forming our memories. And the reason we know that is because people have done what's called functional MRI, and they'll give a person a task and they see what part of the brain lights up. And so we know that certain tasks are derived from frontal lobe function. But the frontal lobe interacts with the rest of the brain. It doesn't act in isolation. And so the left cerebral cortex is responsible for speech and language. So a stroke or damage to this hemisphere in a right-handed person could be an explanation for somebody having a deficit there. Okay. So what happens when the frontal lobe is damaged? So decision-making, executive function, attention, loss of memory. There may be a change in personality, declining intelligence, right? So if there's damage, like in atrophy of the frontal lobes, you may see decreased cognition, changes in emotion, difficulty understanding social cues. Now, the brainstem is our more primitive part of our brain. It's deeper, and its job is mainly as a relay station between the brain, the cerebellum, which is our movement and coordination center, and the spinal cord. It can control facial movements and eye movements, vital functions that we don't think about. And the cerebellum in the back controls our movement and balance. So the deeper brain is where we see a lot of the injury in Leigh syndrome. So these structures are very important relay stations. They are basically the gatekeepers between the spinal cord, cerebellum, and the cerebral hemispheres. And so there are other deeper parts, such as the hypothalamus, which are important in bodily functions. And I think for the purpose of time, I'm not going to go through all of this, but the slides are available. Okay. And then again, you know, all of the brains sections are connected. The importance of being able to communicate in the brain is basically the function of the synapse, and that's a place where the signal passes from one neuron to another cell. So it may be another neuron, and it may be a muscle cell. And we talked about the process of neurotransmission. So there can be problems in neurotransmission, not relaying signals to the various neurons and other parts of the nervous system. And so I think just to try to keep things on time for everybody else, I know I skipped a lot, but I'll be available for the Q&A. Thank you.